Next is cavernous venous malformation. The vascular structures in the in the pediatric can be can be inborn, like the hemangioma, which decrease and regress with the aging, and the other vascular structure is a cavernous hemangioma, or the all of these are considered vascular malformation now. These structures can happen. So uh, when the patient present to you, it is not hemangioma like before, or everything like that was called hemangioma, but it is benless proptosis, benless proptosis. And then the ophthalmoscope, I do feel that fleshy, something fleshy, vascular behind 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 the orbit. Okay, if he can say something, if it is something, if it extend, or like if he can say something. Okay, there is present with well circumscribed ovoid enhancing mass, heterogeneous with early patchy central enhancement, filling as all the vascular malformation with low flow. Low flow vascular malformation. Hemangioma is a low flow vascular malformation. Cavernoma is a low flow vascular malformation. So it needs more time to take the contrast. So the filling in, the filling in, non-distensible slow flow venous malformation, high EDC distinguishes mass from orbital neoplasm, because high EDC is not the number. The high EDC is the feature. This means because we have the diffusion, and you have to look to the ADC, because the hemangioma has T2 shine through. In the diffusion, it will appear with high signal. But when you do the ADC, it will appear as high signal. If there is a tumor, this means that through diffusion restriction, so it will present with high signal in the diffusion and the low signal in the ADC value. Okay, here is, you see the patchy enhancement, and here it is. This, this is the CT, and here it is in the MRI. It is an MRI without contrast, will present with high signal, but in the contrast with, even in the CT or MRI, it will present with the filling in. Okay. Next is the hematoma. You know, in the hematoma, we you can the intraorbit can intraocular can present with due to rupture of it, trauma, and rupture of the intraorbital artery branches following trauma or surgery. Present with, here it is. I'm speaking about that, not that. This means the trauma. This is trauma, but this I'm speaking about that, the retrobulbar hematoma, which present with irregular soft tissue mass involving the posterior globe surface with distal portion of the intraorbital optic nerve. The optic wall fracture, mean optic wall fracture means there is a trauma. Foreign body, search for a foreign body, search for the foreign body, and can also present with flat orbit, flat tire orbit because of the rupture. Okay, here it is examples: retrobulbar soft tissue mass. Here it is the air, because of there is fracture also of the nasal fracture, and there is air here coming to the coming into the orbital, into the orbital soft tissue. And here it is. When you find retrobulbar hematoma, search for the fracture, search for the air, search for a foreign body. The lymphoproliferative disorder can do the same like orbital pseudotumor. Okay, but it will never be painful like it. Never. The expert ophthalmology consultants can know that. The problem with them, when the pseudotumor in the regression phase, when it is not flared, this is the problem. But the clinically, when it is, when the pseudotumor is flared, can differentiate both of them. Both of them come with proptosis. Okay, but here it is not painful like the pseudotumor. Homogeneously enhancing solid mass, intraconal location or extraconal more common, in cases or molds to cranial to optic the optic nerve. It is solid, pliable, homogeneously enhancing. The lymphoma generally, like any hypercellular tumor, the hyper or high cellularity, it will present in the CT with a relative hyperdense. In the MRI, you will find in the T1 relative hyperdense, like the medulloblastoma. All of these tumors, which are hypercellular, will present in the MRI in the T1 as relatively high signal. In the T2, it will present with relatively low signal. It will still high, but not like the other tumor. Mild hyper T2 intensity. Okay. The decrease of the EDC, the true lymphoma, that we agreed, which is the one of the main differentiating points between the lymphoma and the pseudo tumor is the EDC. The EDC is very low signal in the lymphoma compared to the orbital pseudo tumor. Okay, and they present with moderate to marked homogeneous enhancement. Okay, here it is the example. This the lymphoma evolving everywhere. You cannot differentiate where the enhancement. There is uh, the the lesion, and also this we are not sure either this sinusitis or invasion of the lymphoma by the lymphoma. This lymphatic malformation. This the same concept. It is a bit different from the same concept of vascular malformation, but different in the presentation as this the lymphangioma generally is a cystic structure, fluid signal, okay, but have fluid levels due to the hemorrhage. Okay, fluid level. This is not a crucial rule, but this can happen. But mainly the lymphangioma or lymphatic malformation present with fluid signal. Okay, this is the cases that is the fluid due to the hemorrhage. You will find the fluid and the hemorrhagic component. So it appears as fluid level, but this is not a crucial rule. Okay, this is one of the complications. Don't forget the proptosis. The proptosis here. Okay, thrombosis of the cavernous sinus. In this case, in this type of cases, it is very complicated. And I told you it has many. The problem of the orbit is the connections, the venous connections, the nerve connections, the arterial connections. So the orbit also is very helpful because when it is easily to expect a pathology in the orbit. Once there is a pathology behind the orbit, proptosis. It is it is not a hidden organ in the head. So there is a problem. There is proptosis. So you have to search for the reason of this proptosis. We'll do CT for the proptosis, not painful. You will find that there is the most that when there is a problem related to the orbit, kindly, and there is no history of foreign body, kindly go ahead to contrast and check the structure. Here, normal enhanced superior ophthalmic vein, and here ophthalmic vein, and here enlarged, distended, and there is filling defect. So it is thrombosis. It is very near to the cavernous sinus, very near to the cavernous sinus. So you have to assess and give a clear comment on the cavernous sinus when you find a thrombus in the ophthalmic vein. Okay. Next pathology. I do feel I know that I'm a bit chaotic today, but just I want you to make these variable pathologies in your mind. So we are speaking intraconal and some extraconal. I want these pathologies to gathered in your mind without consequences because the differentiating point between these pathologies are bit remarkable. The orbit, the advantage of the orbit. most of the pathologists, you will have the key if you have some experience, some knowledge, and also can search well on the website. The coloboma. Coloboma is herniation. It appears at the site of entry of the optic disc. It is a weak point because of the the optic nerve is there is a defect in the globe. So at the site of entry of the optic nerve, this is the weakest point. So through these points, the defect, the defect, and there is a herniation of the content of the eye globe can go out. This defect in the globe at the optic nerve insertion without pouching of the vitreous retrobulbar globomatous cyst is contiguous with the globe contains non-enhancing fluid of vitreal density. The other pathology is the staphyloma. Okay, this is the coloboma. You will find here it's a bit larger compared to staphyloma. Okay, erythema Chester disease. It is non-Langerhans histiocytosis with orbital Zanzigranulomatous deposits. Infiltrative disease. ISO2 hyperintense on CT. Hypointense on T1. Hypointense on T1 and T2. This granulomatous. Heterogeneous enhancement. So also we have a characteristic MRI finding. It is hypointense in T1 and in T2, and this is the post contrast. Okay, you'll find here while involve everywhere. In the extracorneal compartment, we have the lacrimal gland tumor, which could be epithelial or non-epithelial, and the details of the lacrimal gland will be explained in the next lecture. But let's start with polymorphic adenoma. Polymorphic is the most common benign neoplasm of the glands, parotid polymorphic adenoma. Okay, 30 to 50 years old patient, slow growth, painless poroptosis, well-defined lesion in the subrotemporal aspect of the orbit, bone remodeling as any benign structures. It doesn't invade, it expand and compress. Okay, risk of recurrence or malignant transformation. There is a risk of malignant transformation, but very low. Okay, you will find here that here in the diffusion and the diffusion there is no significant restriction. Okay, there is in the MRI high high signal. This is the diffusion. There is no there is it is not high so high in the diffusion. It is very high in the very low in the T1, and regard the enhancement, it is almost a homogeneous enhancement. Adenoid cystic carcinoma, the malignant form. Don't forget, adenoid cystic carcinoma means the perineural spread, infiltrating lesion. It is not uncommon and involve a lower range of age from 30 to 40 years old. Here it is, adenoid cystic tumor. Next case, lacrimal gland lymphoma. Lymphoma involves everywhere, but when it is dedicated to the lacrimal gland, search for Sjogren syndrome. Patient history of rheumatoid, cystic changes within the parotid and the other salivary glands, and in the lymphoma, as usual, the low ADC value. Okay, you will find here this in the CT because it is cellular, so should it is bit different from the common presentation of the lymphoma, but you will find here in the diffusion there is some diffusion restriction, and here it is you see the foci of the I just uh, it is you will find here that this foci, this area of low EDC value. Okay, rhabdomyosarcoma. Then the other, in the young age, when I tell you rhabdomyosarcoma, it means 7 years old. 7 years old. And the other differential later on, the muscles. This is the most common mesenchymal malignancy in childhood. In the orbit, 40% of the rhabdomyosarcoma in head and neck. Rapidly progressive unilateral proptosis. The good thing is good prognosis. In the MRI and CT, no specific characteristic, but the age, the age is the characteristic. The age, 7 years old, around 7 years old, like the medulloblastoma in the posterior fossa, but rhabdomyosarcoma until proved otherwise. The key, the biopsy. Here it is, example rhabdomyosarcoma. This is ultrasound, lesion, heterogeneous lesion. And here it is, variable, no rule, contrast enhancement. Some authors say no significant contrast enhancement or mild contrast enhancement. You will find as the lesions of the muscle origin mesenchymal tumor. It is not so high in the T2, different from the common tumors. But the most important is the involvement of the muscles, the age of the patient. Leukemia, just because it can comes in the exam, just because the leukemia can also come and send the mets everywhere. Unfortunately, very very strange disease. It sent to the orbit also the leukemia and can present what also there is the common presentation granulocytic tumors with with the leukemia. This unfortunately, when the patient has leukemia, you have to check every part in the body individually because it is expected to happen have to send the meds or infiltrate any structure in the body. Okay, so we'll find here it is in the you see the retina and the choroid region. You will find them there is involvement that it is not so high in the T2, it is low in the T1, and there is post contrast enhancement. Other pathologies which can come, which involve the orbit, like the osteoma, plasmacytoma, if more than one lesion, don't call it plasmacytoma, call it multiple myeloma, but it's plasmacytoma, maxillary sinus carcinoma, invasion of the orbit, and the meningioma, as we mentioned above, that check the bone for hyperostosis or expansion. And don't forget the fibrous dysplasia with neurofibromatosis. Okay. Langerhans cell histiocytosis and the non-Langerhans cell histiocytosis. Also check the CT for the bone involvement and the associated soft tissue component. There is bone involvement and this expansion. They are extraconal and they invade the orbit from the bone. Thyroid acropathy, thyroid orbitopathy. I'm sorry for acropathy. I said it twice. Sorry. So in thyroid orbitopathy, the rules sparing the tendons, not like the IgG4, the orbital pseudotumor. It follow the most common is the medial from medial rectus, inferior rectus, like that. Okay, this a common sequence, inferior, medial, superior, and the lateral is not involved in most of the cases, but can be involved. It is not. If you see the other features, like the most important is sparing the tendon. On the other hand, the in the orbital in the orbital pseudotumor, there is no sparing of the tendon. Okay. Next is orbital cellulitis. It is very critical disease, and unfortunately, the there is many findings could be misinterpreted in the orbital cellulitis. First of all, we have what's called the orbital septum. the phlegmon, which is inflammatory without abscess formation, and subperiosteal abscess, which is a very important. You see this. Most of the reports cannot describe this. This is subperiosteal abscess. Okay, and this is very common in orbital cellulitis. Orbital cellulitis can associated with this contrast and these thrombosis of the ophthalmic veins. Okay, you see this. It comes from and it's intracranial extension. So it is very critical. And unfortunately, the misinterpretation and the delayed staging of these staging, this is something related to the tumor. But the if you undercall the findings which you see in the orbital cellulitis, this patient may have a lot of problem, because ophthalmic vein thrombosis means cavernous sinus thrombosis. The patient will die. The patient will die if there is cavernous sinus thrombosis few years ago. This means the patient would die. And the intracranial extension easy, and beside that involved the migration through the nerves. You find here that all of these are the pathway to the brain and the intracranial structures. Okay. So the orbital cellulitis, take care, check the diffusion, especially if there is abscess or not. Give a comment on the subperiosteal abscess, true extension, involvement of the ophthalmic vein, the perineural spread through the perineural spread to the intracranial structure, the cavernous sinus. And don't forget to ask for the contrast study. Don't do anything related to the orbit without contrast. Okay. Staphyloma is the other pathology, which like the coloboma, but it is a bit eccentric compared to the coloboma. Here it is. You'll find the coloboma should be defected due to the at the site of entry of the optic nerve, but staphyloma is a bit eccentric, and to be continued in the next lecture. Thank you.